All right, good morning, everyone. So let's, I guess, start the class despite us being only five today. Let me quickly just share my screen. There you go. Can you guys see my screen? Can someone? Yes. Perfect. Thank you so much. I'm going to stop the camera. Okay, there you go. Okay, guys. Let's just make this more class more interactive because there are not many people. You guys can just interrupt me whenever you guys want, or just send me basically what do you call it, a message, through the inbox, basically here, through the chat. Sorry. So today we're gonna be talking a lot about hypersensitivity reactions, where in general we're gonna be talking in a case of we're really gonna talk about how the immune system can sometimes go over like override, not just an autoimmunity per se, but when an out basically a whole, let's say, immune kind of response can exaggerate and can actually lead to death of our vital organs. And we're going to not just talk about the mechanism, I mean, it's like from the immune perspective, but I'm going to be talking a lot about different diseases. So if anyone here is, let's say, interested in like doing medicine or doing any kind of clinical work, this is actually going to be a very interesting kind of lecture. So what are hypersensitivities per se? Well, hypersensitivities, they're basically are, immune responses that have become excessive or misdirected. So as we all know, our immune system will try to protect us against pathogens, toxins, and abnormal cells. That's what they will basically do. They love to do that to, protect us. But sometimes that kind of exaggerate, basically that response can become a bit excessive or even misdirected to the point of like they're not just harming, basically killing pathogens or toxins or abnormal cells, they're actually being directed to be killing normal healthy cells because it's too excessive. And then, of course, this kind of results in damage to your own tissue. And this is what hypersensitivity reactions are. And specifically, it's literally, I like this meme a lot, is because when you have like, SpongeBob and Patrick here trying to protect, their town, they do it, but in such an excessive manner that all around you is basically just destroyed. So the mechanism purely of hypersensitivity. Hypersensitivity always occurs with a sensitization event. So it's an event in where you are, per se, kind of, how can I put it? You're exposed to a certain basically pathogen, or let's say, sorry, antigen, that's the more right word. You're basically taken up by an antigen. And then your immune system is developing a memory response against that antigen. Then, after basically exposure. So after the sensitization event and you get exposed again to that same antigen is when your immune system starts to get basically quite excessive. So in a sense, what I'm trying to say here is that hypersensitivity is actually mediated purely from your adaptive immune system. Because as we know, the adaptive immune system, it requires this sensitization event. It needs for basically this antigen to basically kind of to create a memory response. We know that innate immune cells do not have basically a memory response. They do not recall previous infections per se. They don't do that. And this basically kind of substance that we're trying to basically becoming, let's say, creating an immune response against or a memory response could be as harmless as pollen, as a food protein, or even basically a self molecule mistakenly recognized as foreign. So, these pollen or food proteins, there can be basically like allergic reactions, and we're going to be talking about them. So there's many different types of hypersensitivities. There are basically in four, in a sense where every type is mediated by a certain mechanism. And we're going to be talking a lot about them today and basically how certain diseases can come up. So the first type is IgE mediated hypersensitivity. So IgE Antibody mediated sensitivity means it basically means allergies. These are purely your allergies. Anything that is IgE, so this antibody that of the IgE isotype is technically allergies. So when I basically in an exam, if I ask you like, hey, what kind of, let's say, hypersensitivity is this? And I'm saying there's an IgE involved, it's directly type 1. It's the easiest one to memorize. And we'll be talking about this. And these are basically your allergies. This could be allergy to food, to pollen, to basically dust, you name it. The second one is also antibody mediated, but it's much more IgG or IgM. So these are basically antibodies that have basically are binding towards basically antigens that are found on a extracellular matrix or a cell membrane. So they're binding to basically kind of surfaces. And because they're binding to surfaces, they are activating your immune system too much. This means your complement, this means your macrophages, your neutrophils, etc. So this is still antibody mediated, but it's much more IgG and IgM. Type 3 is very similar to type 2, but the difference is that the antigen that they're binding to, the antibodies, the IgG or the IgM, are not present on basically the surface. They're literally are soluble antigens. They're soluble antigens that are in the blood, and basically you just have to go and bind to them. So this is your type 3. Then you have type 4, which are more T cell mediated. This is the much more different ones. Type 1, 2, and 3 are all antibody mediated. Type 3 is more T cell. So basically, it's more the antigen is sensitizing your T cells, not your B cells to create antibodies. We'll definitely go into a bit more details, and I'll give you different examples of all diseases that can happen here. So, when it comes to basically the types, you have type 1, 2, and 3, which, as I said, they all involve antibodies, and type 4, they're much more mediated by T lymphocytes. So, the different types, let's say, of hypersensitivities, they are very similar in a sense that they're all basically over-exaggerated immune responses, but basically they can differ on the immune component. So, for example, if it's antibodies or T cells, on the timing, T lymphocyte is a bit much more delayed, while type 2 and 1, 2, and 3, it's much more early, it's immediate. The mechanism that causes the injury, the cause of tissue injury, and of course, the disease that results from this process. And I'll definitely be giving you a lot of examples here. So type 1. Type 1 are technically your allergies. These basically, which I am literally suffering from currently right now. So basically, these can be towards allergens as harmless as pollen, as a food like peanuts, as basically just dust, or even basically hair, or basically kind of dan from animals. And these are mostly mediated by basophils and mast cells. And we'll be explaining why specifically these cells. So the basic concept is actually all mediated through IgE antibodies. And it all starts from a sensitization event. So you're exposed to an allergen at the beginning, and the first time that, let's say, you're exposed to it, you do not develop symptoms. So let's imagine that you're basically are gonna become, let's say, allergic to pollen. The first time in your life that you're exposed to pollen, you're not gonna get symptoms. You do not get any symptoms. On the contrary, you just create a memory response against it. It's only the second time that you start to develop symptoms, and then the third and fourth. But the first time, you never do that, and that's called a sensitization. So these allergens can really include pollen, dust mites, animal dander, foods, insect venom, and drugs like penicillin. And for some reason, we're quite sensitive towards antibiotics. This is a big reason why when every time you go to the hospital, they always ask you like, do you know have any sensitivities or let's say allergies towards certain antibiotics before they actually give it to you. But let's imagine that you are trying to develop a, let's say, a type 1 hypersensitivity or allergy response against penicillin. So the first time that you're exposed to penicillin, as I said, you're not going to develop any symptoms. The first time, what's going to happen is that you're going to have basically these molecules of penicillin being released. These are taken up by a dendritic cell and then are presented towards naive T cells. So what's happening here is that your dendritic cells are taking up penicillin, they're going to your lymph nodes, presenting it to your naive CD4 T cells, and specifically through an MHC2, basically kind of way. This is then teaching basically, or telling your naive T cells like, hey, you basically now you've recognized this allergen, which is coming from penicillin. I need you to basically now create a memory response. And that's what they do. They start to basically create a memory response. They create a T helper 2 cell compartment, and T helper 2 cells, they take up this, basically, they present, or sorry, they basically help B cells create a antibody response against this penicillin. And then specifically what they do is they start to release interleukin 4 and 13. So please, I really need you guys to know this. So that's just why they're not in red. What interleukin 4 and 13 does, it tells the B cell to do basically this kind of class switching. So the B cells start to produce IgE antibodies. It's all because of interleukin 4 and 13. So that's what exactly what they do. They start to produce IgE antibodies against this penicillin molecule. IgE antibodies per se, they're very different towards IgA or G or M. And where those antibodies, you mostly see them floating around your blood. IgE doesn't really go through your blood. It actually binds to its receptor that's called Fc epsilon receptor. So epsilon is basically the Greek for E. So that's why they've called it epsilon. So it's a receptor for IgE antibodies. And these Fc epsilon receptors are found on mast cells, on basophils, and also on eosinophils. This is why these cells are very, let's say, kind of involved in type 1 hypersensitivities because these IgE antibodies that are now recognizing these allergens are present there. They're stuck. So literally what you have are a bunch of mast cells and basically blast cells going all around, or basically all around with this massive IgE antibody stuck to them. And they're basically just, these antibodies are specific to an allergen. So what happens is that when a second exposure happens, so let's imagine you're basically now exposed a second time to penicillin. What happens is that this this basically basically a penicillin molecule is gonna bind to two IgE molecules that are present on basically here your mast cell. The binding of these two IgE antibodies to this is gonna cause the mast cell to trigger basically a signaling cascade, specifically Lin and Sick. You don't need to know these, which causes a calcium influx. Technically, it's doing a whole, let's say, signaling cascade to release a lot of basically granules. So when you ever have a look in a microscope towards mast cells or basophils or eosinophils, you're going to see basically the cell that has these small little sacs all around the cell. These sacs are endosomes that carry a lot of basically chemicals or molecules that are going to cause a lot of different types of symptoms. So basically, once they're activated, this is immediate. They start to release these endosomes outside and start to release a lot of chemicals. They can cause us to itch, nausea, vomiting, urticaria, angioedema, bronchospasms, you name it. All these kind of symptoms that are basically pertinent towards, let's say, allergies. So mast cells, basically, they release several basically mediators, and the most immediate ones, so the ones that are stuck in these granules, are histamine, tryptase, proteases, and heparin. These guys are the ones that are causing the most early on, basically kind of symptoms, like the itching, like the redness, a bit of the vasodilation, technically. These things are this is why when we're exposed to an allergen, this is why our symptoms are instantaneously almost. Because these mast cells, they already have them prepared. They don't need to wait for the mast cell to basically, you don't need to wait for them to create it. It's already done. You just need to then for them to be activated, and then you have it released. Later on, basically, if the mast cell is still being activated, it's going to start producing other types of molecules like leukotrienes, prostaglandins, platelet activating factors, and cytokines. And what these guys do is they further push vasodilation and increase the vascular leakage. It can also cause bronchoconstriction. This is basically your bronchioles in your lungs, which we're gonna be talking about very shortly. They're gonna cause them to constrict, so your lungs gonna have typical difficulties to actually breathe. It's gonna cause massive mucus secretions and even much more itching. So usually the acute phase of an allergy is just these four. And if it's acute, you only have very mild symptoms of itching and redness. It's only when these basically are produced that which basically means that this allergen is being exposed much, much more, you start to actually have more severe symptoms. And I'll basically, let's say, talk about this and with the different diseases that we have. So the first disease that we're going to be talking about is allergic rhinitis. This is your most common, let's say, allergy. This is basically allergies that are coming into our nasal cavity. This is basically what it is. So all the type 1 hypersensitivities are extremely very similar to each other. They have a very similar pathology. The only difference between them is the location. So allergic rhinitis happens in the nasal cavity. So what happens is that basically you have, let's imagine pollen getting inside our nose. The first time we have this sensitization event in where we create a anti-IgE antibody response. So you create a memory response of B cells ready to create IgE antibodies against the second exposure. You get exposed the second time, and the first time basically the first acute kind of reaction is the release of these kind of histamines, the release of tryptase, protease, and heparin. And these are the ones that are causing us to start to sneeze, to start to itch, and to start to basically kind of, let's say, even tear up a bit. But if it's basically very acute that the kind of, let's say, the allergen, like pollen, is removed quickly, that it stops there. Only if the pollen starts to persist and you have a further, let's say, activation of your mast cells are start going to produce leukotrienes, prostaglandins, all these different types of cytokines that I talked about, platelet activation factor, and these what they're going to do is further push the vascular leakage. They're going to be basically pushing your globulate cells to produce mucus, and you're going to start producing a lot of different cytokines that are going to bring other cells, specifically basically from eosinophils, from anti-helper 2 cells. When eosinophils and T helper 2 cells start to come in, specifically eosinophils, they start to release a lot of toxic proteins, specifically like major basic protein, which are technically literally damaging your epithelial cells. So with allergic rhinitis, at the beginning, the early stage of it is very harmless. You just have the very common sneezing, a bit of itchiness, a bit of redness that you get. It's only later when these mast cells basically are becoming much, much more activated that they start to release a lot of different types of chemicals like leukotrienes and prostaglandins and other cytokines that bring other cells like eosinophils. They come in and they start to release even much more cytotoxic, basically chemicals like the major basic protein. Another example of basically type 1 is allergic asthma. So this is exactly the same as allergic rhinitis. The difference is the site of where the allergen is coming. Now the allergen is found in our lungs. And what happens is that, again, the first time we have this sensitization, we create a memory response against that allergen, against the subsequent, basically kind of exposure to that same allergen. What happens is now our mast cells that are there, they're literally getting extremely activated and they're releasing basically at the beginning histamines and all this kind of stuff. So at the beginning, when they start to release histamines and all these kind of the first early on mediators, what happens? So this is basically your bronchus. This is basically in your lungs. You have these massive bronchus, these kind of, let's say, capillary beds technically, and they have these alveoli. These alveoli, if you guys don't know, these are literally kind of little sacs that these are the ones doing all the gas exchange. So this is how we're able to breathe because you have alveoli that are able to basically kind of exchange, oxygen and carbon dioxide. And they basically let them enter into our basically our bronchus, which basically has our basically veins and arteries and all these capillary beds that are taking up this oxygen. What happens is that the mast cells that are here, they get so triggered from this allergen and they start to actually cause and start to release a lot of this histamines and everything. And they're what they're gonna do is they're gonna cause basically a thickening of basically these kind of walls. They're gonna do a lot of this kind of vasoconstriction, basically. They're gonna make all of a huge inflammation that this is gonna vasoconstrict. So suddenly this is the opening of your bronchi, which is quite big, and you need it to be quite big because you need to let oxygen pass through. What happens is that now this constricts and you have a lot of mucus secretion because of these histamines that are being released. And again, if this actually goes into the late phase and where now we have leukotrienes, you have prostaglandins, you have now eosinophils coming in. So again, getting into the late phase, similar to what you have in urinitis, basically you have a remodeling. So they start to remodel this whole bronchi into a more permanent kind of stage, and where your airways start to really thicken, you have a huge increase of smooth muscle mass, and basically you have fibrosis. So this is your normal airway, basically your bronchus. It's very quite big. It has a very big opening, has a very thin layer of smooth muscle around that helps to contract a bit. What happens is that when you have so much activation of your mast cells, which are releasing all these late effector molecules like prostaglandins and leukotrienes and all these things, they're just bringing all these different types of immune cells in there. And basically, what happens in there per se is this basically causes, for example, your smooth muscle around to really thicken. And basically, you create a lot of this kind of fibrosis. So this is fibrosis over here. This is basically damaged kind of muscle, basically tissue that's been trying to be being repaired. And the issue with this fibrosis is that it's extremely, it's not elastic. It's very constrict. And that's an issue because here, this bronchus, they need to be able to kind of expand, in and out because this is our lung and they need to be flexible. Here with fibrosis, they're not going to be flexible and they're not going to be able to really kind of help the oxygen basically kind of diffusion. And what you have is this basically massive decrease of your lumen. So this is basically what happens in asthma during the late phase. So again, as you can see, there's a very similar mechanism of action here, where you have really the beginning of it is just very sensitive. There's nothing really much happening here. It's only that after basically a while that you have this remodeling of your bronchi, with the basically late phase kind of leukotrienes and prostaglandin molecules. Another one of type 1 is food allergy. Again, these can be basically when the allergen has now reached your gastrointestinal mucosa. These could be, for example, peanuts, shellfish, eggs, milk, soy, wheat, so many different types, basically. And again, what happens is that you have basically in stages. The beginning is technically the release of histamines. Histamines, what they do is they basically, of course, they cause this itching and stuff like that. You're not really gonna feel them in your stomach, but what you're gonna feel with histamine specifically is that histamine stimulates your smooth muscle to contract, and this is what you get abdominal cramps. So the beginning when you eat, for example, let's imagine that you're allergic to peanuts or let's say shellfish. When you eat them, you're gonna directly feel it because histamine is the very early on kind of molecules being released. Well, they're gonna start to going to contract your muscles in your basically in your stomach, sorry, more in your intestine, and that's gonna give you the cramps. If basically, of course, that allergen still persists, what's going to happen is you're going to have leukotrienes and prostaglandins, like I said, and they're going to push even much more this basically kind of, they're going to make your whole intestine much more leaky because they're just going to make it, more vasodilate. They're going to increase basically the permeability and make your gut leaky. And this is where it gets very dangerous because if your gut is leaky, it's going to suddenly, by accident, leak all these histamines, all these prostaglandins, all these leukotrienes into your blood, and it becomes systemic. And this is why later on, when you have basically you're exposed to a food allergen, despite the food allergen being in your stomach, because of the late effector molecules like leukotrienes and prostaglandins, your gut is becoming very leaky, and these all these mediators are releasing into the blood, and they're causing these rashes in your skin because now they're everywhere. It's more systemic. These rashes that you see here, they're called urticaria. Urticaria basically, we see this quite often when people are eating basically an allergen. It's simply because the intestine is becoming leaky. Anaphylaxis is the last type of, let's say, type 1 hypersensitivity I'm going to talk about today. It's the most severe form because this is basically now it's systemic. It's everywhere. So what happens, technically, allergens are everywhere in your bloodstream. They're not confined to somewhere. They're not confined to your stomach. They're not confined to your nose. They're not confined basically towards your lungs. No, they're everywhere. And what happens is technically the same. Your basically mast cells are being releasing in the beginning the histamines and all these early on mediators, and they're causing basically kind of redness and biodilation everywhere. It's and then of course after that you start having the release of these late ones, the leukotrienes and prostaglandins, which are pushing more and more this vasodilation and permeability. So what happens in a vascular kind of thing is that because your veins are being so vasodilated, they're increasing their permeability. So a lot of fluid is being lost from your veins and arteries to the point that you actually have a massive drop in blood pressure because there's no more basically volume in them. So this is extremely dangerous. These leukotrienes they can go back into your lungs and they can cause the vaso basically the bronchoconstriction. So basically, there's bronchus to constrict even more. So you don't have a lot of this gas exchange. You can go to your larynx and basically it gets inflamed. All your skin gets inflamed. We get, for example, this poor boy that has an anaphylactic shock, and where it's exposed. Basically, it's his eyes are just shut because there's so much basically inflammation. So this is the most severe type of type 1 hypersensitivity you'll ever get, and where the allergen is everywhere in your body and is causing the mast cells everywhere to be activated. And that is severely dangerous because this can actually lead to death within hours. But because it's severe and it can lead to death in basically from an hour to two or a couple, you need to basically people that are, let's say, know that they have that can basically develop anaphylaxis, they need to always carry with them an epinephrine pen. So we call them an EpiPen. So it's literally it looks like this EpiPen, which is literally an injection that you hit in your muscle, and this releases epinephrine. Epinephrine, what it does, it literally does the reverse of these. It actually vasoconstricts. It doesn't vasodilate anymore, it vasoconstricts. It relaxes the bronchial smooth muscle and it inhibits the mast cell degranulation. So it's trying to reverse all the things of histamines and all these prostaglandins and leukotrienes. And this is super quick. This literally will help you within minutes. So it's extremely important for people that have anaphylaxis shocks to always have them in hand. EpiPens usually in Europe and in basically countries all around, they cost around, let's say, $80 or something like that. A bit tad expensive, but they're still manageable. The issue, actually, this is just out of for fun for you guys, or a fun fact. In the US, EpiPens, if you do not have a good medical insurance, they can go from $650 to $750. And I've heard a lot of cases where they've reached even 1,000. So to me, that's ridiculous that such a life-saving kind of apparatus is sold that expensive. That imagine people that do not have a medical insurance, what happens to them? So this is something that's been in a huge debate in the US, specifically in the medical sector, in where this is just abnormal because the production of an EpiPen does not cost that much. So it should not be sold by that ridiculous amount. So now to type 2 hypersensitivity. Type 2 hypersensitivity is very similar to type 1, but the difference is the type of antibodies. So the type of antibodies that you carry are not IgE, they're IgG or M. So what happens is that these antibodies are binding either to extracellular matrix or basically antigens on found technically on a cell membrane. So once they bind to basically antigens here in the cell membrane, what they can do is they can cause an overexaggeration of your immune cells. So they can activate your complement system quite actively. They can cause NK cells to come in and release all these granzymes and perforins. They can actually cause your macrophages to come into phagocytosis, your neutrophils to release all these different types of lytic enzymes, and you name it. So this is basically type 2. So it's technically again the basic concept of it is IgG or IgM antibodies binding to antigens located on cell surfaces or extracellular matrix molecules. This is extremely important for you guys to know. Please do not that the antigen has to be on a cell surface or extracellular matrix molecule. They have to be. If they're soluble, that's type 3. So this is why I don't want you to get confused between type 2 and type 3. And this basically leads, as I said, to the activation of your complement, phagocytosis, antibody-dependent cellular cytotoxicity, which is the technically NK cells killing, but also basically the antibodies can bind to receptors on a cell, which can cause either blocking or actually receptor stimulation. So I'll give you examples of these. So the first one, which is basically a quite common one, hemolytic transfusion reaction. So this is technically where these are basically when you're given the wrong type of blood. So as we all know, everyone has a certain blood type. People either have A, B, AB, or O. And what differs between these types is the glycolipid that's found in your red blood cell. So basically, if you have red blood cell type A, it means you have a certain glycolipid that gives you that type A. If you have B, you have a different type of glycolipid. So let's imagine that I myself, I'm basically tired. Basically, I'm O. I'm getting basically a transfusion of blood that is type A. Well, that's an issue because what happens is that this glycolipid, I don't have this. This is foreign. So I'm actually going to create an immune response. So you're going to create a sensitization response, and where I'm going to create a memory response at the beginning. Once I get the second time exposed to this kind of red blood cells, the type A, the memory response is going to produce antibodies against these, how can I put it? These basically kind of glycolipids that are found in the red blood cell type A. They're going to bind and they're going to do the same, basically, as I said, activate your complement system. These are going to create your basically your membrane attack complexes to destroy this. They're going to also allow monocytes or macrophages to basically come in and kill. And what happens is that technically these red blood cells are being destroyed. They're not allowed in my body. But what happens is that when these are destroyed, red blood cells contain a lot of heme. So heme is this basically groups that are basically capturing oxygen, these hemoglobins. These are extremely toxic, and especially if they come to the kidney. Once they get into the kidney, they can actually do something called acute kidney injury, which they can basically, in a very short amount of time, do a lot of injury to your kidneys. So repetitive hemolytic transfusion reactions can actually destroy your kidneys per se. Then you have hemolytic disease of the newborn. This is also very similar, but this more involves pregnancy. So, for those who don't know what basically this Rh antigen is, you guys have always, of course, when you go and check your blood type, they always will tell you you're A positive or you're A negative or you're B positive or negative. There's always a positive and negative sign. That is your Rh basically antigen. It's an antigen that you either have or don't. So that's what that negative or positive means when you have your blood type. So you either have the antigen or not. So what happens in the case of basically hemolytic disease of the newborn? In this case here, imagine that you're a mother that you basically are Rh negative. You do not have that antigen. You basically are pregnant and your baby has the antigen, which is shown here basically in blue. What happens is that during the first pregnancy, Desensitization occurs, especially during delivery. These red blood cells are being exposed much more at a higher quantity to the mother. These are now basically going to your mother. Specifically, the mother is immune system is going to create a response against it because this RH, this antigen, we don't find it. We don't the mother doesn't have it. So it's going to see it as foreign. So it's going to develop basically a memory B cell response against the RH. And this is a sensitization. So usually the first pregnancy, everything goes well. It's only in your second and third and fourth pregnancies. It's only after your first pregnancy that you get symptoms. So again, in the second pregnancy of this mother, the baby also has the Rh antigen. What happens is that the mother now basically gets exposed to this, basically red blood cells here, and they basically now the memory B cells are able to actually recognize this and produce an abundant amount of antibodies against that antigen. These antibodies then go into the baby and they start binding to the Rh antigen in the red blood cells and they start to kill it. They start to activate your complement system. They start to activate your basically your whole immune system to kill it. So what happens with basically this baby is it's going to have severe fetal anemia, meaning that there's so much killing of the red blood cells that the baby is going to go anemic. There's going to be, again, this release of hemoglobin. Hemoglobin, other than just going to your kidneys, it goes to also your liver and it damages your liver. When you damage your liver, you release something called bilirubin. Bilirubin is this protein that is heavily found in your liver, and this is the one that basically it gets stuck to your skin and to your cornea, and this gives this yellow color. So when you see people that have yellow skin or their eyes are very yellow, the cornea is very yellow, it means that bilirubin has been released so much from your basically liver. So that is an indication that your liver is failing. So this is what also happens in these kind of kids. They have yondus, meaning that the liver is actually being killed or destroyed along with the kidneys. And you have something called hydrops fetalis, which is where, because there's so much activation, because remember, when you're activating your complement system, you get release of the C5a and C3a. These C5a and C3a are bringing your neutrophils, they're creating a whole inflammation. Well, this causes a huge accumulation of fluid, and this can be extremely severe. This is what hydrops fetalis is. It's this increase of fluid that can kill the whole baby. Then you have autoimmune hemolytic anemia. This is exactly very similar, basically, in a sense that the difference here is simply that for some reason, you're creating an autoimmune response against something towards your own red blood cell. Something in your own red blood cell is basically being recognized from your own immune system. So this is an autoimmune disease per se as well. And again, you have your own antibodies binding to your own red blood cells, and they're basically being destroyed. And you have the same symptoms again of anemia, of basically kidney injury, liver injury, you name it. Another basically type 2 is called Good-Pasteur syndrome. Good-Pasteur syndrome is technically when you have antibodies against type 4 collagen. This is a type of collagen that is found in the membranes of lungs and kidney, and specifically glomeruli and of alveoli. So alveoli are these little sacs that we spoke about in the lungs. Glomeruli are basically these kind of capillaries that are basically doing a lot of this kind of filtration. These are the filtration units in kidneys. And what happens is that you basically get these antibodies binding to this collagen found here. And again, you get the destruction of them. So you literally have a huge issue with your kidneys and lungs in Good-Pasteur syndrome. So this is much more of how antibodies can do basically the killing through activation of the immune system. But sometimes antibodies can also do damage by blocking receptors or activating them. And the blocking of receptors is an example that I also spoke about in my autoimmune class is myasthenia gravis. So as we all know, basically we have these neuromuscular junctions, and where you have these kind of neurons that are literally at a junction next to your muscle. In normal cases, What happens is that when this basically neuron is activated, it's going to release acetylcholine. Acetylcholine is going to basically bind to acetylcholine receptors in your muscle, and this is going to cause basically your muscles to contract. So this is how we're able to control muscle contractions or movement, for example. In myasthenia gravis, what we see is that you create an antibody response against the acetylcholine receptors. So what happens is that they're basically blocking the acetylcholine to do anything. And this can cause paralysis. But of course, other than that, it can also internalize these acetylcholine receptors inside, but it can also activate your complement system for them to be destroyed. So technically, you don't have any more receptor for the acetylcholine, so you don't have any more actually muscle being able to kind of contract. Then you have Graves' disease. Graves' disease basically is basically a type 2 hypersensitivity, and where you see an antibody and where how an antibody can actually do a lot of damage by just activating the receptor. So again, we spoke about Graves' disease. I'll just quickly go again through it. In normality, this is your pituitary gland. It releases this thyroid-stimulating hormone, which binds to the basically the thyroid-stimulating hormone receptor. This is found in your thyroid. So once this TCH binds to this receptor, it causes your thyroid to release thyroid hormones, which are very important for metabolism. They're very important for basically our kind of blood pressure, our heart rates, and our heat regulation, a lot of homeostatic basically processes in our body. But the issue with thyroid hormones is that you don't want too much of it because it can be very toxic. So what happens is that the thyroid hormone itself creates a negative feedback loop. It goes to basically your pituitary gland and it stops your pituitary gland from releasing TSH. And this is basically how this is regulated. So you don't have an excess. People with Graves' disease have a B cell response. They have B cells that are basically releasing these antibodies that are binding to this TSH receptor. This causes the TSH receptor to be activated and release an abundant amount of basically thyroid hormones. That despite being so much of them that they're going into your pituitary gland to stop the TSH, it doesn't matter. They're going to keep producing thyroid hormones. These people are very actually anxious. They're very basically having a lot of issues with anxiety because their heart rates are extremely up. They have really bad issues with their basically blood pressures. They actually have some sort of way heat intolerances. A lot of different homeostatic basically conditions are being messed around with. Type 3. I'm gonna give you guys a quick, let's say 5 minute break. So now it's 8:48. Let's come back, let's say at basically now it's 8:49. We can come back at 8:54. It's just a small, quick little break. All right, guys, let's go back again to this. Can you guys see my screen? Can someone just let me know if they see my screen?
Yes.
Thank you. Okay, type 3 hypersensitivities, they are very, very similar to type 2. The only, let's say, difference is that the antigen is floating. It's just basically floating around. That's the difference. And basically, what happens is that because it's floating, you get the formation of an immune complex, which basically means, in simple words, it's the antigen binding to the antibody. So when you see an antibody binding to an antigen, that's called an immune complex. So what happens in these immune complexes is they start to actually deposit in blood vessels, in kidneys, in joints, and in the skin. This is a big issue because if this immune complex, this antibody and antigen, were just floating around in the blood, that's fine because technically they're going to be technically taken up by a macrophage. But because they deposit in blood vessels, kidneys, joints, and skin, that's where basically we get kind of killing. Or let's say not killing, but mostly these kind of dangerous side effects. Because now the blood vessels, the kidneys, the joints, or the skin are at risk. So I'll give you examples of this. Systemic lupus erythematosus, SLE. So this is basically a very well-known autoimmune disease in which I'm going to be explaining to you what's happening here. So what happens is that sometimes we have in our body cells that are basically dying quite severely, and they do apoptosis. And what happens is that when they do basically apoptosis, they release a lot of basically self antigens. And when you have a reduction in apoptotic clearance, what happens is that these self antigens are being much more exposed. And then specifically, double-stranded DNA. DNA is not really immunogenic for B cells. It's not going to create an antibody response. But double-stranded DNA, and especially in eukaryotes, they're very compact. They're very, let's say, kind of folded. And they're folded, as we all know, through histones. Histones bind to them and they fold them. Histones are actually reactive. They actually can create B cells to become reactive against them. And this is what happens is in these apoptosis, when you have double-stranded DNA lying around freely with the histones, these are taken up and you're creating a B cell response. And specifically, you're creating antibody responses against these kind of histones. And what happens is that this histone and this antibody are depositing in vascular beds. They're depositing in kidneys, in joints, in the skin, all these places around. So they're going everywhere basically. And because they're literally staying there, they're depositing there, they're basically gonna cause activation of your MAC complexes, sorry, of your complement system, which is gonna release C3, C5a, and it's basically C3a, all these different ones that are gonna cause all the immune cells to come in and release a lot of different types of, kind of, let's say, reactive oxygen species, a lot of these kind of perforins and granzymes, all these different types of cytokines and chemokines that are going to be causing a lot of inflammation. And this is what happens with SLE. So it all starts with the antibody binding to the antigen that is soluble. And then they deposit in all around basically different types of tissues. And the tissues basically, because they're so close, the activation of the complement or the other immune cells is so close to those tissues that they're gonna get damaged. So here in this kind of case, for example, you have a boy basically here that has systemic lupus erythematosus. It's gonna have a lot of issues with basically kind of inflammation all around the body. But one thing that is super important, or let's say very unique to SLE, to the lupus, is this butterfly rash. It's actually a very diagnostic kind of tool people use or doctors use. usually people that have lupus have this rash. They have rashes all over their bodies. But specifically, they have this kind of, they call it the butterfly rash because it looks like a butterfly. It's this kind of wings that are basically on your cheeks, and then your nose is also basically kind of inflamed. And this is very indicative of lupus. I don't know specifically why it does this shape, but that's what you see a lot in lupus. Another one is post-streptococcal glomerulonephritis. Name sounds very confusing, but it's actually quite simple. So, glomerulonephritis, itis, anything you see with itis means inflammation. So, there is actually an inflammation in your glomerulus, in your basically kidneys, and this is because of a post-streptococcal infection. So, what happens is that when you're infected with streptococcus, so this is a bacteria, you have the streptococcus that is binding basically to antibodies. This streptococcus basically is floating in your blood, so this is why it's type 3. It's binding to the antibodies, and these are depositing in your glomeruli. So these are basically the filtration units in your kidney. And then you get basically the activation of your complement and your immune cells to do all the damage. Another one is serum sickness. So this is where you're literally sick from your own serum. Because what happens in your blood, sometimes we get a large quantity of foreign proteins entering, and they're being basically bound by IgG or IgM antibodies. These are creating these immune complexes, which are depositing all over your blood vessels and tissues. So you actually get activation of your complement and neutrophils and all these things. So you start developing kind of fever, rashes, joint pains, any basically organ that is being touched or being deposited with these basically complexes, they're getting being destroyed. And this is an example of what you see with serum sickness. You see these massive rashes all over your body. So this is basically more systemic. And then comes type 4 hypersensitivity. Type 4 is very different to type 1, 2, and 3. It's not antibody mediated. It's more T cell. And we call this more delayed because in these ones, they usually come immediately after basically when you have this sensitization period. Usually the second exposure, symptoms occur within minutes or basically hours. It's really quick. Type 4, no. What you see with type 4, you actually start to see a more delayed kind of symptoms. They appear 24 to 72 hours after an antigen is being exposed. And there's two mechanisms for this, basically. It's usually either T helper cells or cytotoxic T cells. So again, T cell mediated. I'll give you basically here one example of it. Contact dermatitis. This is usually happens when you touch certain chemicals like nickel or poison ivy. Because what happens with nickel and poison ivy, they have molecules that they act like haptens. And what a hapten is, let me show you this in a very nice kind of graph or figure. So these basically, let's imagine that you're touching poison ivy. Poison ivy has this haptens that basically are released. They come into your skin, they go inside. And what these haptens do is they bind to self proteins. And specifically, for example, here they bind to skin proteins. This skin protein was never really recognized by your immune cells. What haptens do is they actually make it much more attractive. So because of basically this skin protein that has now these haptens, they basically make them be uptaken by your dendritic cell at a higher rate and basically much more faster, much more quicker and efficient. That's what a hapten does. It suddenly makes self proteins much more, uh, let's say, presented. So your dendritic cell comes in, presents it to your T cell, and it creates a memory response. Suddenly, again, against your second allergen exposure, what happens? Again, you're exposed to poison ivy again. The hapten comes in and increases again, basically their recognition of the basically them from the memory T cells, and you basically have this release of a lot of cytotoxic granules and everything, which is causing a huge inflammation. This is contact dermatitis. This is what happens when you, for example, touch poison ivy and you basically have these rashes coming up because of these cells. And these rashes, they usually do not come up like immediately. They happen after 1 day or 72 hours because T cells take a bit longer than antibodies to work. Type 1 diabetes is another example of type 4 hypersensitivity, and where we start to create an antigen or a sensitization period towards a protein that is found in your beta cells. These cells in our pancreas that are releasing insulin. So after the sensitization period, basically basically T cells or CD8 T cells will recognize these beta cells and will start killing them. Of course, CD4 T cells will still also be able to recognize them and will create a lot of release of inflammatory cytokines. So this is an example of your basically your pancreas, and in these kind of brown, these are your beta cells. So this is basically, no, how it should supposed to be look normally. This is how it looks like in type 1 diabetes, and where you don't have much of those beta cells anymore, and you're not producing basically insulin. So guys, thank you so much for listening. Thank you so much for coming today. Is there any questions or anything that you guys want me to go over or explain, or just have any interesting questions that you want to, I don't know, ask? Yes, Ryan.
دكتور هلا all the example mentioned in the slides need a first antigen exposure, then in the second one they will create the immune response.
Exactly. Every single time.
Okay.
It's always because it's all, how can I put it? An adaptive immune system. The adaptive immune system always needs the antigen to be exposed first.
Okay, thank you.
No worries. Any other question, guys? Anything you guys want to ask or have or interested in? All right, guys. If not, have a nice continuation of your week and weekend, and see you guys on Tuesday. Please stay safe. Yes, Ryan, tell me.
Doctor, I want to ask you, have you posted the survey examples?
The survey examples, no, because I posted the video, which has them.
No, you mentioned you had an example of the
Oh,
written survey.
for you mean the essays, right?
Yes, yes,
Yeah,
that's
that's
it.
right. Yes, the essays. Yes, the essays. I'll put them up basically now today. I'm still finishing up because I had two similar essays that were the similar question, but I want to give you two different ones. So just to give you more practice. So I'm just finishing up the final one so I can post them up today.
Okay, thank you, doctor.
No worries, guys. Have a nice one.